Welcome to the cardiovascular system. The cardiovascular system is complex, and on your exam, it is split with the respiratory system, so you should only have 4 to 5 questions on the cardiovascular system. This is a picture of your heart. You have your aorta up here that has the 3 arteries coming out of it. You have your superior vena cava and your inferior vena cava. You have your pulmonary veins, which go to your lungs on each side. You have your right atrium, your left ventricle, your left atrium, and your right ventricle. You have 4 chambers of your heart. You have your right and left chamber, your right and left atrium, and your right and left ventricle. Like I mentioned before, there are 4 valves in your heart. You have the mitral valve, the tricuspid valve, which controls blood flow from the atria to the ventricles, the aortic valve, and the pulmonary valve, which control blood flow out of the ventricles. It's important to note that you do have 4 valves. Let's go over some of this important anatomy. You need to know this anatomy in the cardiovascular system because it's essential for coding. Systemic circulation delivers blood to all of the body cells. Pulmonary circulation eliminates carbon dioxide and gives blood oxygen. A vein carries deoxygenated blood, and it carries blood to the heart. Arteries do the opposite. They carry oxygenated blood, and they carry the blood away from the heart. The pericardium think of that as like a sac that covers the heart, and it protects the heart. The pericardial cavity contains fluid for the heart to float in. The wall of your heart and the wall of arteries have 3 layers. The epicardium, which is the outer layer, the myocardium, which is the middle layer, and it's also the muscle layer. The endocardium, which is the inner layer of blood vessels, and the Purkinje fibers. We talked about how arteries and veins carry deoxygenated and oxygenated blood. The exception to the rule is found with the pulmonary arteries. They actually carry deoxygenated blood away from the heart to your lungs, where the blood will become oxygenated before returning to the heart through the pulmonary veins. Because, like I said before, veins carry deoxygenated blood and arteries carry oxygenated blood, you should remember this exception to the rule as it could be a trick question. Blood enters the heart through 2 large veins, the inferior and superior vena cava. They empty oxygen-poor blood from the body into the right atrium of the heart. As the atrium contracts, blood flows from your right atrium into your right ventricle through the open tricuspid valve. When the ventricle is full, the tricuspid valve shuts. This prevents blood from flowing backwards into the atria while the ventricle contracts. That's the main reason for the valve. As the ventricle contracts, blood leaves the heart through the pulmonic valve into the pulmonary artery and to the lungs where it is oxygenated. The left side of the heart, the pulmonary vein empties oxygen-rich blood from the lungs into the left atrium of the heart. As the atrium contracts, blood flows from the left atrium into your left ventricle through the mitral valve. When the ventricle is full, the mitral valve shuts. This prevents blood from flowing backwards into the atrium while the ventricle contracts. That's what the mitral valve does. As the ventricle contracts, blood leaves the heart through the aortic valve into the aorta and the body. It's important for you to know the circulation process. You have 20 arteries. And of those 20 arteries, they branch off and become smaller, called arterioles. Your arterioles branch off and become capillaries. Capillaries pick up carbon dioxide. Capillaries then deliver oxygen and nutrients to your cells. After that, they pick up carbon dioxide. Capillaries are thinner than hair. They then turn into venules, which turn into veins, and then go to the heart. It's important for you to memorize this process. This is a diagram of all of the arteries and veins throughout your body. You don't need to remember all of them, but if you do know your bones, which you should, then they're kind of similar to that. You have your common iliac artery, your femoral, which is your femoral bone is right here as well, your tibial artery, which your tibia bone is here. You just need to know what area of the body that these are on when they are speaking of them. So at least know where to find this in your book if you do have a scenario. Now I want to talk about the branches. Turn to Appendix L. We're going to talk about this more with coding in a minute, but I do want you to understand the process of it. From your aorta, you have branch arteries that branch off. Those are called first, second, and third order branches. Think of it as a road. Your aorta is the main portion of the road. You can either go off into the left subclavian road, the left common carotid, or the innominate road. And once you go off that road from the aorta, you're in your first order or your first branch. Now, say you go into the left common carotid. This blue portion represents the first order. If you go off into your internal or external common carotid, that's your second order because you went off the road again. And then if you go off again, that's your third order. So talking about the common carotid, you went from the aorta to the left common carotid. So when you went into that left common carotid, you were at the first order. You didn't go in through the innominate and then the carotid, right common carotid. You went to the left common carotid and then you went into the external carotid. From there, if you went into any of these, that's your third order branch. It's important to understand that, and that's why I kind of drew it out for you, just because some of these codes are going to go based off of that. Now, this appendix is assuming that you are starting from the aorta. And what I mean by starting, there's a catheter that's going in. A catheter is in there to look and diagnose the patient, but we're going to talk about that in more detail here in a minute. The first section I want to talk about in the cardiovascular system that you're sure to have a question on is the pacemaker and implantable defibrillator section. Patients get pacemakers and defibrillators that have arrhythmia. A permanent pacemaker is a small device implanted into the chest to send electrical signals to start or regulate a slow heartbeat. An implantable cardiodefibrillator, called ICD, looks like a pacemaker, but it's larger. The ICD will send a low energy shock that resets the abnormal heartbeat back to a normal pace. So the pacemaker regulates the heartbeat. The defibrillator shocks the heart to put it back at a normal pace. This is what a pacemaker defibrillator system looks like. For every pacemaker and defibrillator system, you have a lead, and the lead are these wires right here that are coming off of the pulse generator. So leads are also called electrodes. They are sending the electrical stimulation. So lead equals electrode. Remember that, write that in this section. A pulse generator is the battery. It's the battery that controls the rest of the system. And it's usually implanted in your chest area. So lead equals electrode or wires, and pulse generator equals battery. Here's how you code a pacemaker or defibrillator system. First, you need to ask yourself, was it a pacemaker or a defibrillator being implanted? Was it being inserted? What was being inserted? The generator, the leads, or were both the generator and leads being inserted? Was a temporary system being inserted, or was a permanent system? Because there's different codes for both. Then you need to say, was it single, dual, or multiple? Single is when it's going into one chamber of the heart. Dual is when it's going into two chambers. And multiple is when it's going into multiple, more than two. An atrial or ventricular, or both. So is it going into the atrium or the ventricular side of the heart, or both? And was it an insertion of the system, a replacement, an upgrade, repositioning, or a removal? Like I said, single chamber is when the lead is inserted either into the atrial or ventricular part of the heart. A dual chamber is when it was both in the atrial and ventricular part of the heart. Some guidelines that you need to know and write in this section are: if the pacemaker or defibrillator system are not stated as permanent or temporary, you should default to permanent. For an upgrade from a single chamber system to a dual chamber, meaning in both chambers, you should code 33214. For an insertion of a permanent pacemaker, look at codes 33206 through 33208. These codes include the battery, generator, and leads. Do not code insertion of generator separately. Replacement of a permanent pacemaker, you should use codes 33206 through 33208. These codes say insertion and replacement or replacement, but you should also use a code from 33234 or 33235 for the removal. Revision of a skin pocket is included in most procedures unless it is done alone. That's important to note around that code as well. Turn to the cardiac valve section. First, you have your aortic valve. A transcatheter aortic valve replacement is called TAVR or TAVI. These are coded by approach. 3 add-on codes for cardiopulmonary bypass grafts are used with codes 33367 through 33369. These procedures require 2 positions and should be coded with modifier 62 on all codes used. Angiography is included in codes and should not be coded separately. These are all notes you should make in this section. Mitral valve section is 33418 through 33419. These are used for transcatheter mitral valve repair. Write TMVR next to 33418 and 33419. Your pulmonary valve section is 33477 and it is used to report a transcatheter pulmonary valve implantation. Write TPVI next to 33477. Write a note in section of codes that are 33474 through 33478 to look at guidelines when coding these procedures. Now let's talk about what coders call CABG coding, coronary artery bypass grafting, CABG. A coronary artery bypass graft, CABG, is the most appropriate open heart surgery used to treat coronary artery disease. And remember, coronary is your heart. So these are arteries of your heart. Codes 33510 to 33516 are for venous grafting only for coronary artery bypass. So that means a vein is being used for grafting, not an artery. As per CPT, these codes should not be used to report the performance of a coronary artery bypass procedures using atrial grafts and venous grafts during the same procedure. It is only used when they are only using a venous graft. 33533 to 33548 are atrial grafting for coronary artery bypass. These codes include harvesting of most all arteries, and the harvesting should not be coded separately. There is an exception to that rule. The guidelines state when an artery is taken from your arm, it can be reported separately with 35600 for radial artery. That is an important note you should put in this section. Also, if the femoropopliteal vein is harvested, which is in your leg, you can code 35572 separately. All other grafts harvesting should not be coded separately. If a venous graft used and an atrial graft is used. That's a combination graft. And you should code these from 33517, which are the atrial graft codes, through 33530. If venous graft and atrial graft is used, that's a combined graft. And you should code from 33517 through 33530 for the vein graft. Those are add-on codes. You code the artery graft first, and then you will use these add-on codes 33517 through 33530 for the vein. Do not use codes from the vein graft only. They made special add-on codes for you to use here. Harvesting of the graft is included unless the graft was taken from the arm, like mentioned before, or the femoral popliteal. If it was taken from the arm, use 35600. Again, 33517 to 33530 are combined atrial venous grafting for coronary bypass. As per CPT, these codes are used to report coronary artery bypass procedures using venous grafts and atrial grafts during the same procedure. These codes may not be used alone, as they are add-on codes. Add-on code 33530 is for reoperation of a coronary artery bypass procedure or valve procedure more than 1 month after the original operation. So if the scenario or note says that this is a reoperation, or they are having it again, or they had it in the past, you will use this add-on code with your normal procedures. You should make that note in your book. If a vein is ever harvested endoscopically, you will add code 33508 in addition to your regular codes. To report harvesting of an upper extremity vein, again, see code 35500 for that radial vein. Here's a scenario that I want to do together. A physician performs a 3-vessel autogenous, 1 venous, 2 atrial coronary bypass on a patient who had a previous CABG 2 years ago, utilizing a saphenous vein, radial artery, and the left and right internal mammary arteries. Select CPT codes for this procedure. Take a shot at this. Pause the video, and I'll be back with the answers. You should have gotten 33534, which is used for the 2 artery grafts. Remember, there were 2 arteries and 1 vein. Then you would have gotten 33517, and remember, that's the add-on code because it was a combined artery and vein. You would have not used 33510 because it was done with an artery, and guidelines state you must use the add-on code instead. So that makes up our 2 arteries and 1 vein. Then you had, the note scenario said that it was a second operation. They had one a while back. So we would use the reoperation code 33530. They also named the arteries that were harvested. And we can't code any of them except for the radial artery because it was in the arm, and remember that was a tricky guideline, so we could have coded 35600. So your answer should have been D. Now turn to your abdominal aortic aneurysm section. In this diagram, you can see the aneurysm, which is a bulge in the abdominal portion of the aorta. There's a risk that it could rupture, just like a balloon could rupture if it gets too big. And obviously that's going to be really bad if that happens. Endovascular repair of abdominal aneurysms are coded with 34800 through 34834. Turn to those codes now. These are also called EVAR, EVAR, endovascular repair of an abdominal aneurysm. These procedures are done endoscopically. They repair with mesh stents. It is supposed to replace the bulging that we just saw. These codes are coded based on what part of the abdominal aorta is affected, and we'll look at a diagram of this in just a second. The abdominal aorta divides down into other parts. One part of it is called the visceral aorta. That's between the diaphragm and your renal artery, which is on your kidneys. Your thoracic aorta, which is above the diaphragm, and your infrarenal aorta below the renal artery. In your CPT book, at the beginning of this section, you should have a diagram that looks like this. You should mark it just like I have here so you know where the thoracic aorta is. See, it's above that blue arrow, which is the diaphragm. Your visceral aorta, which is in between your diaphragm and your renal artery. And your infrarenal aorta, which is right here underneath your renal artery. To code these, determine if the procedure was done open or endovascular. Where was it? Was it infrarenal or visceral? And how many and what type of prosthesis was used? EVAR is coded with 34800 through 34848, like I said earlier. A direct repair, which is the open, is coded with 35001 through 35152. This section starts right here, and see how I put EVAR in parentheses. Here's a diagram of them doing an EVAR procedure. You can see the mesh, which is controlling the aneurysm. 34800 is endovascular repair of infrarenal, so that's the part below the renal artery of an abdominal aortic aneurysm. And they are using a aortic tube prosthesis. If they are using a modular bifurcated prosthesis, one docking limb, you should use 34802. I put a note in my book that says to see parts of the aorta, turn to the table of contents where I showed you to fill out that diagram and label it at the beginning of the section. If they are using a modular bifurcated prosthesis, two docking limbs, you will use 34803. If they're using a unibody bifurcated prosthesis, you will use 34804. And for an aorta uniiliac or aorta unifemoral prosthesis, you will use 34805. Notice how I have labeled from 34826 to 34834, and really it should be from 34820 on the previous page to 34834, that these are open repairs, not endovascular, because you don't want to get that confused. The next section is for the endovascular repair of a visceral or infrarenal aorta. There are guidelines here that you should review. Notice on 34845, it is an endovascular repair of the visceral aorta and the infrarenal aorta. And it's a little blurry because it's smeared, but I have that labeled on this code. Above that is the visceral aorta. See how I have that circled. And for the endovascular repair of an iliac aneurysm, you will turn to this section, starting with 34900. Notice on the page where 35102 is and 35103, I have labeled iliac vessels. And on 35132, I have iliac artery. So that's different. Iliac vessels are different from an iliac artery. I have a note on top of this page that says watch out, make sure to pick the code based on if it's a vessel or an artery with these.